what I want, 'cause I can see that thing from the front. You the type to spin when they do. Independent, baby, got your own. Like, ooh, can't nobody do it like you. So baby, can you tell me what to do? Yeah, 'cause I've been waiting all night to slip, slip, slide. There's something in the water of trying. Let's dip, dip, dive in. Don't make me wait so long. I'ma slip, slip, slide it. You're looking like you really wanna try it. Let's dip, dip, dive in. Don't make me wait so long. I will pick up all your calls on site. You can fly to Acapulco for the night. I could tell you on that ball shit I like. 'Cause when you said you paid the bill, had me singing like, ooh, can't nobody do it like you. So baby, can you tell me what to do, girl? 'Cause I've been waiting all night to slip, slip, slide. There's something in the water of trying. Let's dip, dip, dive in. Don't make me wait so long. I'ma slip, slip, slide it. You're looking like you really wanna try it. Let's dip, dip, dive in. Don't make me wait so long.
It look like it's a vibe, but I don't know until I vibe with it. I'ma get behind and grip them thousand slip and slide in. I got a Rolls Royce out the door, but you might as well to ride with. She know if she dealt with me, she might have to let me dive in. I like to do things to make you smile. You say you fucking with me, babe, I'ma stop fucking around. You know, I take you out, I gotta take you down. Tonight, I gotta take around before I ride, for sure. They don't make me wait, I'm a real player, I wanna play. And you be looking like the way you look, the way you taste. And if it check out the mirror, I'ma bring a check out and bustin' that down. But I gotta bust before I come.
Looking like you really wanna try it. Let's try. Don't make me waste your time, so you can't slip it off, baby. Don't waste this love, I'm waiting on the off, baby. Don't make me wait so long. Slip it off, baby. Don't waste this love, I'm waiting. Slip it off, baby. Don't make me wait so long.
Kodak, yup.
Slip, slip, slide it.
Slide,
Ooh,
slide.
Jason Derulo.
Yeah, Kodak.
Check it. I can tell you got what I want. 'Cause I can see that thing from
Kami beritahukan kepada seluruh peserta seminar
independent, baby, got your own. Like, ooh.
untuk dapat kembali ke tempat duduknya masing-masing karena sesaat lagi seminar selanjutnya akan segera dimulai. Sekali lagi kepada seluruh peserta seminar untuk dapat kembali ke tempat duduknya masing-masing karena sesaat lagi seminar selanjutnya akan segera dimulai.
For the night, I could tell you on that ball shit I like. 'Cause when you said you paid the bill, had me singing like, ooh, can't nobody do it like you. So baby, can you tell me what to do, girl? 'Cause I've been waiting all night to slip, slip, slide. There's something in the water of trying. Let's dip, dip, dive in. Don't make me wait so long. I'ma slip, slip, slide it. You're looking like you really wanna try it. Let's dip, dip, dive in. Don't make me wait so long.
It look like it's a vibe, but I don't know until I vibe with it. I'ma get behind and grip them thousand slip and slide in. I got a Rolls Royce out the door, but you might as well to ride with. She know if she dealt with me, she might have to let me dive in. I like to do things to make you smile. You say you fucking with me, babe, I'ma stop fucking around. You know, I take you out, I gotta take you down. Tonight, I gotta take around before I ride, for sure. They don't make me wait, I'm a real player, I wanna play. And you be looking like the way you look, the way you taste. And if it check out the mirror, I'ma bring a check out and bustin' that down. But I gotta bust before I come.
Looking like you really wanna try. Let's try. Don't make me waste your time, so you can't slip it off, baby. Don't waste this love, I'm waiting on the off, baby. Don't make me wait so long. Slip it off, baby. Don't waste this love, I'm waiting. Slip it off, baby. Don't make me wait so long.
Kami beritahukan kepada peserta hands-on Dr. Gigi Kami beritahukan kepada seluruh peserta hands-on bedah mulut. Hands-on akan dimulai pada pukul 13.30 di ruang Jasmine lantai 3. Sekali lagi kepada seluruh peserta hands-on bedah mulut. Hands-on akan segera dimulai pada pukul 1.30 di ruang Jasmine lantai 3.
Fulfill my wish. Make me feel good, make me feel nice. Give me your loving all through the night. Make me feel good, make me feel nice. Give me your loving all through the night. Make me feel good, make me feel nice. Give me your loving all through the night. Yeah, all through the night. Yeah. All through the night, yeah. All through the night, yeah. Your loving, yeah. Give me your loving. Give me your loving, yeah. Come on, twirl, woman, ooh, what you did to me. One touch from his hand, set my love free. Set my love free. Set my love free. Make me feel good, make me feel nice. Give me your loving all through the night. Make me feel good, make me feel nice. Give me your loving all through the night. Make me feel good, make me feel nice. Give me your loving all through the night. All through the night. Give me your loving. Make me feel good, make me feel nice. Give me your loving all through the night. Make me feel good, make me feel nice. Give me your loving all through the night. Make me feel good, make me feel nice. Give me your loving all through the night. Yeah. All through the night, yeah. All through the night, yeah. All through the night, give me your loving. Give me your loving. Every time you come around, you know I can't say no. Every time the sun goes down, I let you take control. I can feel the paradise before my world implodes. And tonight had something wonderful. My bad habits lead to late nights, sitting alone. Conversations with a stranger I barely know. Swearing this will be the last, but it probably won't. I got nothing left to lose or use, or do my bad habits lead to white eyes staring into space? And I know I lose control of the things that I say. Yeah, I was looking for a way out, now I can't escape. Nothing happens after two. It's true, my bad habits lead
Ladies and gentlemen, the third main seminar will be presented by our speaker, Associate Professor Dr. Cacawin Angkurawasapon, DDS, DSCD PhD with the title The Art and the Science of Smile Design in Aesthetic Dentistry, Unleashing the Power of Digital Technology, and will be moderated by Dr. Gigi Denis, Fkg Subspesialis, KE Konsultan, MDSC PhD. To Dr. Denis, the time is yours.
Hello everyone, I want to wish you a very good afternoon after your lunch, and we are going to continue with our next session of lectures with our speakers from Thailand. Sawadee krap, Ajahn Chachawin. But before that, I want to introduce our speaker by reading his curriculum vitae. Associate Professor Dr. Chachawin, in 2004, he graduated from his DDS, Prince of Songkhla University. In 2014, he got a certificate of advanced graduate study in prosthodontic from Goldman School of Dental Medicine, Boston University. In 2014, he got a Doctor of Sciences in Dentistry from Goldman School of Dental Medicine. And he is now full-time faculty of Prince of Songkhla University since 2004. And he will deliver the lecture with the title, The Art and Science of Smile Design in Aesthetic Dentistry, Unleashing the Power of Digital Technology. Now I want to pass the session for Ajahn Chachawin to deliver your lecture. Khop khun krap.
Thank you very much. Good afternoon, everyone. Selamat sore, right? Today, I will speak on a subject that lies at the heart of my work as a prosthodontist, the art and science of smile design in aesthetic dentistry. This topic bridges the realm of clinical precision and artistic intuition, inviting us to explore not only the technicality of dental restoration, but also the profound psychological and emotional dimension of a smile. As a dental professional, we do more than restore function. We craft confidence, reshape self-esteem, and enable human connection. Our responsibility extends beyond the operatory to the social and emotional well-being of those who trust us with their care. This is why we must continuously refine our skill, embrace innovation, and expand our understanding of the art and science behind a smile. Today, discuss will challenge conventional ideas, inspire collaboration, and push the boundary of what we can achieve in aesthetic dentistry. Let us engage fully, think critically, and strive to set new benchmarks in our shared pursuit of excellence. I look forward to sharing this journey with you and welcome the opportunity to contribute to the collective advancement of our profession. Thank you for your attention, your passion for dentistry, and your commitment to make a difference. Now let's dive into the fascinating world of smile design. Okay, let me use this microphone. Hello, hello, hello. Hello. Okay, it's good now. Thank you. See, now we're going to start the topic. My first question, why do people need to do their smile design? Why people seeking for dental cosmetic? According to the survey in the United States, they found out that most of people who walk into our clinic, they're asking for smile design because of they want to improve their self-esteem. They want themselves to look more attractiveness. Because human, we are not living alone. We live in a society. We sharing, we caring, and we talking. We have interdisciplinary. We discuss with the other people. So when you're making themselves look better, you also improve your self-confidence. It found that when you're talking to someone you have not met before, your first impression, you will look at your opponent. 47 of the 70, according to the study, 47 they found that they were looking at the smile of who you're talking with. And then 30% of their eyes, they smell their clothes and their hair. So what do you think? If you recognize this celebrity, you know who is she? The Black Widow, right? If you have a watch movie. This is her picture when she was a young age. If you notice that her teeth is slightly crooked, is crowding, but after she got some bracing and some aesthetic restorative like the veneer, her smile is looking better. And this guy, I think all of you know him. You know who is he? Tom Cruise. Yes, this is a real picture when he was a teenager. He came out from the poor family, so he has not been take care of his teeth when he was young. But after that, he got his new set of teeth. That make him look more smarter and look more attractiveness. So if we can create a new smile for the patient, you can change their life. But for the conventional way to do that, it needs a lot of skill, it needs of model work, it needs of guessing work. But for the digital, you can improve everything, make it more easier. So right now, the trend in this time, we're changing from the analog world into the digital world. Then, if we understand that, we can improve our work. The first question I always ask my students all the time, what is beauty? Beauty is like the world standard. Everybody agree in the same thing, or it's just like a local small group of the people? This question is everybody want to know. I like this person, another people like this person, but if you go to another country, are they still looking nice as the same as we thought? Maybe or maybe not. So they try to analyze that. They use a lot of the picture of the beautiful celebrity, a lot of the famous people. They're gathering a lot of them and they try to analyze, is there anything in common for this attractive and beautiful celebrity? They found out that most of them, they have their face is symmetry. On the left and on the right side is almost, it's not the mirror like, but it's almost identical on the both sides. And they have a certain specific ratio of their forehead, mid-face, and the lower face. Our job is we try to manage the lower part of their face. It's a smile, it's the lip. So, our job is try to improve the lip of the patient and the teeth of the patient. It's saying that you can have a nice teeth, but if the nice teeth is in the wrong position, it is the same as you have a very nice picture, but you put it in the wrong frame. If you did not put the nice picture into the right position of the frame, everything could be look weird, look strange. So we have to balance it to make it looking better. The fundamental of smile design, the principle is we can make it and we can show it to our patient right before we touch any teeth. So patient can see what is going to happen to her at the end. We can discuss, we can explain to them what is the benefit and what is the risk, what is the cost you have to pay right before. So patient could see that what's going on to her and she can making decide. From my experience, I found out that this technique is help us a lot easier to convince patient to go for the treatment because they see the final result immediately. So they're making easier decision to I will go with this treatment or not. Okay. Then, as I told you that our teeth is just a part of the smile. Our lip is a frame. So the most important thing is you have to know the relationship between your teeth and the lip that is as a frame. Most of the time, we are going to analyze around 6 or 7 parameters. Is tooth exposure at rest, smile line and lip mobility, incisal edge position, smile width, labial corridor, interincisal line and the midline, occlusal plane and commissural line. For the first parameter, we're going to take a look at the tooth exposed at rest. How do we measuring it? The tooth exposed at rest is we going measuring from the lower median border of the lip to the incisal edge. If you want the teeth to look young, to look more like a teenager or more like mid-20, 30, you need to expose of your maxillary incisor estimately around 2 millimeter. If your tooth exposure is less than 2 millimeter, it will look older. In contrast, for your mandibular central incisor, when you're getting older, you will see it more. So if you made it in the right position, your upper incisor is supposed to show just a little bit in the rest position and make your patient look younger. See? However, if you take a look a little bit more closely, according to previous study, they did not they did not separate the lip shape. Even this celebrity, I think you know that, right? Lisa? Yeah. Her smile is look attractive and beautiful, but however, her incisor edge is show up more than 2 millimeter. So there is more recent study, they classify a little bit more in detail about the lip shape, straight, moderate, and high. If you have a different lip shape, the incisor display going to be different too. According to this study, Dr. Kim in 2017 found out, according to study of Dr. Kim 2017, we found out that for the lip which have a straight lip, incisor edge showing going to be around 2 or 3 millimeter. For moderate is around 3 to 6 millimeter. And if you have the higher lip, like the Cupid bow, it's going to can show more than 6 millimeter. We have to integrate, we have to know all of this information because the tool, the equipment we have right now is we can design the teeth. But if we don't know where the teeth it should be, it could be useless. And another parameter is a smile line, high smile line or low smile line. For the high smile line, when the patient is smiling, you will see all of their teeth and a part of their gum. For average smile line, you will see most of their teeth, sometimes upper lip can cover teeth a little bit. And for low smile line, the upper lip will cover a cervical part of their teeth. Luckily, most of the time when patient walking into our clinic is going to be the average smile line. Low smile line is just 20% and high smile line is 10%. But sometimes you have to be careful. Even patient has a low smile line, but when they're going home, sometimes they just like try to look themselves in the mirror. They retract, they try to see what the treatment they got. So right now, even if patient have a low smile line, it could be a difficult case for you sometimes if patient a little bit picky. Another thing you have to take a look is the lip mobility, how far the lip will move. In average, lip mobility is around 6 to 8 millimeter. That means in this case, incisor edge at the rest position show up around 4.5 millimeter. After patient smile, according to average number, it's going to be 6 plus 4 is around 10 millimeter. That means when she smile, we will see the whole teeth. It's nice position. But in some time, patient has a lip mobility that not according to the average number. For example, in this case, Her incisor show up is around 6.5 millimeter, but after she smiled, we could not even see her cervical third of her teeth. This is called hypolip mobility. That means even in the natural position, it look nice, but after she smile, it's not look good. For the case like this, you have to discuss with the patient. You may need to alter something, either make your teeth a little bit shorter at the rest position, or make your lower lip move a little bit lesser by using some like Botox, or maybe train smile together in order to restore your new teeth. And another category is maybe the hardest. It's called hyperlip mobility. This case, patient has a incisor edge show up just around 3 millimeter, but after she smile, this is how her lip move. It became a gummy smile immediately. In this case, if the patient walking to our clinic and asks for your restoration, I want my smile looking better, it might not end up with just only the restoration. You might need something else. Let's say you may need some Botox, or may need some surgical part to reposition your muscle attachment. You may need some kind of like surgery. Some cases maybe even need to do a Lerford or orthodontic surgery. Sometimes it depends on the overall. This is the reason why we have to know that overall big picture is the frame of your teeth. Another thing is the incisor edge position. This is, personally, is most important for me because it's where everything starts. If you could not find where is the incisor edge position, you would never know where the tooth it should be. In this case, patient coming in and she don't like her smile. She wanted to improve her teeth look better, want to increase more natural, want to make her teeth pointy like it's never worn out. So I start smile design for her. Between this one, if we use the existing incisor edge position as a reference, it's going to be this one on the upper one. But if we move her teeth a little bit, make it a little bit longer, close to the lower lip, this one you will get a better tooth proportion and also still have a good and nice smile for her. According to the study, most of the time, people like that when they do smile, incisor edge is just right about lower lips. Not only the incisor edge touch the lower lip, but lateral incisor, canine, and premolar is very important also. This case, if you notice that incisor edge position is just like 2 millimeters from the lower lip, but on your posterior teeth, like the canine or the premolar, has been covered by the lower lip. So the smile curve is called inverted. When it inverted like this, if you made it like this, it's going to be like the old people because it's the sign of the worn out. And it's a form that the less attractive possible. So we need to make it a little bit like this, a gull shape. Then you have to making decision for this case. Either you put the incisor edge a little bit longer to restore the curve, or cut the incisor edge of your posterior teeth. The better way is try to make the incisor edge position of your anterior teeth, lateral incisor and canine conform with the lower lips. Yeah, it will look nicer. In previous case, if you decided to make it just the teeth is in head like this, if you decided to make the teeth just look like a gull shape by increase the incisor range, when patients smile, the lower lip will cover their teeth. Okay. And another one more thing, incisor edge position. If you notice that the lateral incisor going to be a little bit shorter in comparison with the central incisor. For the good-looking, naturally smile, especially for the women, if you want it more feminine, we make it a little bit more soft. Lateral incisor is supposed to be a little bit shorter than central incisor. And this is my case. Patient walking in, want to restore her smile because she about to getting married. She said, the doctor, I just finished my orthodontic treatment and I'm about to get married next year. I want to come to see you and make my smile better. And then I do some restoration, do some current whitening, and I did a veneer for her at the end. And this is how it look like. It's looking a lot better. Another parameter is the smile width, how wide it is supposed to be. Do you think how wide it is look more attractive for you? When you smile, you see just premolar, just canine, or first premolar? In this study, they put a questionnaire and asked the participant to answer the question. There is two things you have to look in this graph. The black dot is the mean aesthetic rank. It means that if you got a higher number, patient, most of the time people feel it look more nicer. For the bar graph is a number of subjects that include in this study. They found out that if you smile wider, you see into second premolar or first molar, it look more attractiveness. So if you perform a restoration for your patient, you did just canine to canine, it cannot be nice. Because according to this study, if you see only the canine to canine look nice, mean aesthetic ranking is the less. You see more, it look more better. So you can use this data to propose a treatment for your patient. You did canine to canine, it's not enough. It's supposed to be at least from the first premolar to first premolar, or the second premolar to second premolar. And another one more thing is the labial corridor. If you made it like this, sometimes people will feel that it's a little bit too full. But if you made it something like this, you see a lot of black triangle over here, you will feel that your arch is too narrow and too much the black space. So it's supposed to be somewhere here in the second and the third picture. In our job as a dentist, if patient walking like this, sometimes you can help them by making restoration of first premolar and second premolar a little bit over contour. This way it will reduce space of the black triangle for a patient. And for the inter-incision line, it's supposed to be straight as possible. According to this study, they try to find out that what is the number that most of the patient acceptable. Yeah. They found that most of the time for the dentist, if the teeth has been canting more than 6 degrees, is called unacceptable for the dentist. But for the patient, acceptable level is reached to 10 degrees. And then this one is another study which I like it a lot. This one is study about the midline. Dental midline coincident with the facial midline. If the 0.0, that means it's coincident. This one is deviate for 1 millimeter, 2 millimeter, 3, 4, and 5 millimeter. Do you think what is the accept number for the most people who are not a dentist? What is accept number for the people who are not a dentist when it is deviating? Let me show you this picture again. This is Tom Cruise, right? Have you ever noticed that he has midline shift? Have you? He has midline shift for almost 4 millimeters. Most of the time, people did not even realize that Tom Cruise has a midline shift. He is the one who most good-looking guy in the world for almost 10 years. That means most of the time in real life, not in the dental chair, in the dental clinic, people could not notice that if the midline has been shifted for around 4 millimeters. As long as it's perpendicular to the earth, parallel to the, it's not canting, it's not leaning back, and it's not leaning to the left, to the right. It's just parallel, that's fine. So the mean threshold for the dentist usually it's somewhere around 2 millimeters, but for the lay person it's around 4 millimeters. If you found that your patient has a midline shift for around 2 or 3 millimeters, personally I recommend you that don't try to propose patient to go for the orthodontic treatment. I mean, it's over-treatment, not necessary. Unless they have something else, like they have malocclusion, or the tooth position is a little bit rotating, canting, inappropriate spacing. Yeah. Otherwise, just let it be. Within 2 or 3 millimeter, that's totally fine. And another thing, occlusal plane and commissural line. If patient has a canned occlusal plane, it will look very, very unattractiveness. I will show one of my patients, this case. She is very, very good looking woman at the mid-20. She just graduated, not for the long time. She come to me and said me that, doctor, I want to restore my smile. Whole my life, patient always mock me about my teeth. You can't teeth. Every time she smile, everybody will be looking at her teeth, and she lost a lot of her self-confidence. And now she about to getting married. So she asked me, doctor, can you help me? I want to make it better. So I discussed with her this case, because you have like, your midline is canting. Your occlusal plane also inappropriate on the quadrant 2 is a little bit too high. If we want to make something, we have to restore the quadrant 2 to make it longer. I proposed this treatment plan to her, and we found that on the quadrant 3, this area, lower teeth may be gliding a little bit in order to increase the length of the teeth on your left side. And she said it's okay. She wants to look nice because it's her wedding. Then I did a veneer for her. After that, she's very happy. She said that this is the first time in her life she could smile confidently. And because she very happy, so in her wedding day, she sent me her picture. You see, our smile design, our restorative can change the patient's life. Not only to make tooth good looking, but make them have more self-confidence. They're happy with themselves. Okay. And I will go a little bit further to the dental analysis to take a look at how the teeth is supposed to look alike. Actually, there is a lot of things we have to go. There is a 14 parameter. You have to take a look in order to make the teeth look nicely. But today, I will discuss only about tooth proportion and the height and the width, because that one is important for designing. The rest of it is you have to go in depth in detail for how to make it happen. The tooth proportion is how the tooth is look related to each other. It has been studied for a very long time. What is the nice proportion? What is supposed to be looking good? In the past, we used what we call the golden proportion. How we measuring it? We measuring the proportion of the teeth by how we visualize it. We're looking at the front of the surface of the patient, the frontal view, and we measuring how width it is, we could see. So the width we see in this position is not the actual width of the teeth. Actual width is this one in the blue line, and this is the white one is the width of the teeth that we use for calculating. At the beginning, we try to use what we call the golden proportion. Golden proportion has been used for a very long time, since the ancient time in the Greek. They used to make like the Parthenon building. They used to make a nice architecture in the past. However, after we try to put this one, the golden proportion, or somebody is called God proportion, into the dentistry, we found out that for the golden proportion is the upper one. Most of the time, studies showing that patient does not like it because canine is look a little bit too narrow. Plus, as you are a human, and every human is different. As all of you have seen patient before, you will notice that some of them has a wide teeth on the posterior width. Some of them have a narrow posterior width. How is possible to use only just one number to apply with every single patient? It's impossible. Let's say for our Asian people, most of the time our posterior width is wider than the Caucasian. Then it's nearly impossible to create canine looking like this for your patient. Plus, even you can make it, it's still not looking nice. So right now, what we are using right now, it's called RED proportion, recurrent aesthetic dental proportion. The width proportion between two adjacent teeth as viewed from the frontal should remain constant progress successively distally. That means the ratio between the central with the lateral to canine, and canine to first premolar is supposed to be constant. And another one more thing is the proportion of the tooth. The proportion of the tooth is we calculate by measuring the width and the height of the teeth. Studying show that most of the time, the proportion of the tooth is around 75 to 85% in the population. It depends on who is your subject. But one of the famous technicians and people use this number as reference a lot by Pascal Manier. They study in the real tooth, in the human tooth. They found a clinical cloud, which they found it from the dental stone model. They're measuring incisal edge into the cervical. The proportion of the central incisor is around 85%. But if you study anatomical crown from the tooth that has been extracted, you measuring from the CEJ to the incisor edge is around 78 to 87%. And for the Asian people, it's around 72 to 78. That means our teeth is somewhere around between this number. And this is the width and the height of the teeth. The width of the teeth, in general, we use around 8.5 or 8.6 millimeter. And the height is supposed to be somewhere 10.2 to 10.5. From my experience, for the Asian people, if you made it somewhere 10.5 is about right. If you made it around 11 millimeter, like this, is okay, it's good looking for the Caucasian people. So according to this study, you have a tentative number to start with for your patient. One thing you have to remember that when you design something for your patient, there is no cookbook. Everything you have some average number and you adjust it to adapt to each case by case. Let's say a patient has like the masculine guy, 2 meter, you made the teeth look really nice and short, it will look funny. In contrast, if your patient is a young-looking woman, the size is around 160, and you use the same teeth as the guy who 2 meters tall, it will look ridiculous for them. So you have to adjust it. Then the past, I told you that what we have to consider. Now we're going to show you that how we're going to use that information that I just provide to you to use for our decided case. In the past, when we decide the tooth, we have a patient teeth, and then we make an impression, and we do a wax up, mock up. As a dentist, you might appreciate that, oh, this one is a good looking waxing. It looks nice. But question is, how do you know that it will look nice in the patient mouth? Because when you have just only the teeth in your laboratory, or your technician have only the teeth, they don't have the lips. They don't have the frame of the picture. It could be end up like this. This picture, obviously, she's not a triplet. I just used a Photoshop to put the teeth in different positions. It could be a little bit too long. Your lower lip could cover incisor edge position, as I told you, it's not look attractive. Or it could be perfectly fit. It's nice. Or maybe it's a little bit too short. This is the problem of the conventional way. You would never know how it's going to look like in the mouth because you have no lip in the lab, right? So they try to develop. How are we going to improve? How are we going to utilize the technology that emerged into our profession? At the beginning, we try to use it's like the keynote or the PowerPoint to do a smile design. This digital smile design has been study has been improved extensively through the past 10 years. When I was a dental student, we use it. Everything has to be done manually. We put it everything like step by step. We try to do everything like manual. It's very primitive. We have to put every single thing, single teeth by ourselves. We try to superimpose. We try to make it looking better. But the protocol has been developed all the time because we have better technology. Now we use intraoral scanner. When I was a dental student, no scanner is available for us. So after we embrace our technology, we use it and we improve it. Right now, you can use, like, for example, triage scanner, or you can use iTero to digitalize information of your patient into the computer. And right now, they have a lot of software that help you to design for the patient. You can use either 3Shape or DSD software. This software is enhanced communication between your patient and your lab technician, and also with you. It can more predictable and precise outcome as it increase patient acceptance rate through visual simulation. Let me explain to you step by step. It's going to be 4 steps. First is data acquisition. You can use photograph, you can use video, intraoral scanner, or CBCT sometime if you need to orthodontic treatment together. You can use digital mock-up to analyze the smile. You can take a look at how it's going to look on the patient facial. You can alter the proportion, and you can tailor-made it to the patient need. Then you can use all of this one, and you adjust talking to the patient, asking for patient permission. Are you agree with my treatment plan? If you want the final result like this is what you have to go through. Let's say like cow lengthening, you bleaching, orthodontic surgery, or whatever. It depends on situation. And then you can create a fabrication restoration based on approval designs. Case example, I will show you that how I'm going to make a veneer smile transformation for the patient with digital. This case, I use the digital smile upgrade for the patient approval. I use CAD/CAM fabricated both veneer and to do a 3D printing model for the patient. This case, patient coming to our clinic, to my clinic, and she told me that I want to improve my smile. My friends always mock me. They say that you are a little bunny. You are a little bunny. Your teeth is a little bit too long, and she feels uncomfortable with that. When I take a look into her mouth, it seems like if you want to improve your smile, there is many things, there is problem we have to correct. First, obviously, the color. She has history of use tetracycline when she was a kid. So her teeth is a little bit too dark. It's tetracycline straining. Her teeth look obviously a little bit too labial and a little bit too long. See? And her gum is uneven. See? Up and down is uneven. I have seen it. In this case, I discussed with her, if you want to go for the ideal treatment, you need orthodontic treatment. You need to align the lateral incisor to put it back into the nice position in order before you get any restoration. This way, it can preserve a lot of your tooth structure. Plus, you also to intrusion, your two front teeth and central incisor, put it in a little bit. Then we just did something later on. But she told me that, doctor, I'm a little bit too old to go for the bracing. It's going to look funny to me to have a bracing in my mouth at my age. So she denied orthodontic treatment. Then we have to go through the non-orthodontic option. So I put her picture together and I use a software for smile design. This one is an extraoral picture of my patient, and this is intraoral picture. With this software, you need at least 2 pictures, in extraoral and intraoral picture together, and we can do design. Let me show you how we do it. Because you use two pictures superimposed, so you have to set the reference point for the software. After you set the reference for the software, you can setting up where is the midline, facial midline, and occlusal plane. And after you align two pictures together between the smile picture and intraoral picture, you put it in the software and you can design it. You will see that this software is only the tool for you to utilize. Without the knowledge where is the tool is supposed to be, without the knowledge what is the proportion is supposed to go, you could not make it right. So you need at least the basic knowledge that which one is look good for the patient. See, with this software, you can stimulate what's going to happen to the patient. After seeing the patient very impressive what it could happen to her, what's going to make her looking better. At this time, you have to discuss with the patient. Okay, I show you that we can end up as a result as I show you, but what is the price you have to pay for? For example, in this case, we notice that the teeth in this area, this quadrant number 2, 3, and 2, 4, the gum is a little bit too coronal. We have to do some aesthetic crown lengthening. The height of zenith of central incisor is uneven. The lateral incisor here, because your distal part is a little bit too labial, it's slightly rotating. And your premolar in this area is a little bit, you need to cut the gum out. And also you need to reduce a lot of your incisor edge position in order to make it nice. You need to cut it short. Some of your teeth might need to perform endodontic treatment if you deny orthodontic. You may need to kill your teeth and RCT it. If you decide to go with it, denying orthodontic treatment. After discuss and negotiation, the GA said that it's okay, I would take a risk. I don't want to go for the ortho, just go for the non-orthodontic treatment. So in this case, I propose to the patient is, I do aesthetic crown lengthening, I do tooth bleaching, and then I perform the restoration for her. And this is the case. I show. This is the original one. After I perform bleaching, the tooth color is looking a lot better. And I also do a crown lengthening to make the height of zenith. It looks more even and more beautiful. If you notice that most of the time, case like this, after you do any operation, you do some kind of treatment for her, most of the time patient will smile bigger. Because in the past, when she didn't have confidence in her smile, she smiled like not 100%. But when she happy more, she will smile bigger and wider. This is something you have to a little bit be careful. And then I use the mock-up from what I show her. I 3D printing model and I made a mock-up in her mouth, seeking for her approval. It is like a blueprint for your final restoration. Are you okay with that? After she said yes, so I start do her preparation, and then I made a provisionalization. And with the digital power, we no need to use any PVS anymore for the case like this. We use intraoral scanner, scan it, send it to the lab, and you can also recheck your work with this software. If you realize that some area your preparation is not enough, some area preparation is not nice, it's a little bit too less, you can just delete it from the software. Let's say if you don't like it, this canine, if you think you should preparation more, you just delete it here, preparation more in the patient mouth, and rescan only just one tooth. You no need to pack cord and re-impression the whole thing. That make your life easier, and then send to the lab to fabricate it. Then the lab 3D printing the model that they scan to them, and they fabricated the final restoration. And this is how it ends up. You see, before and after. With the digital, patient could see what's going to happen to her. Patient could see the final result right before we touch her tooth. And then you have a happy patient. Another case, because of digital, we did not use only for the front teeth. We can use something like for the full mouth reconstruction also. This case, I will show you that. This case, I got it from my colleague, orthodontist. She sent this case to me and asked me that, Dr. Gon, could you help this patient? I just removed her bracket. It has been done. Orthodontic could not do anything more than this. Can you help her? Then I see the patient, I ask the patient, okay, ma'am, what can I do for you today? What is your problem? She told me that, doctor, could you help me? I just got my orthodontic treatment done, but right now I cannot chew at all. I can only bite with my front teeth. So I take a look at the side of her teeth. And I was like, are you serious? I mean, you said you just got orthodontic treatment, it has been done, and is this how it's occluded? And take a look on another side. Oh my God. Only two front teeth.
I'm sorry,
Yes.
only 5 minutes left.
Okay. I just have 43 minutes. I think I have like 10 more minutes, right? Okay. Okay. And in this case, so I show them, I talk to the patient that you have only the front teeth in contact. You need to restore your back teeth. Okay. At the beginning, I feel a little bit frustrated. This is supposed not to be after you has been done with orthodontic treatment. So I looking back into the data, what's going on with the patient. Oh, at the beginning, she has a severe class T malocclusion, and patient denied to go for surgery. And this is how it looked at the beginning. Her teeth is very crooked and had a severe O-jet overbite here, severe class T, and her teeth also is worn out. So I use a digital scanner to scan to digitalize your patient information. And with this digital, you could see immediately the red color, that means it's in contact. The green one, that means it's not in contact, it's open space. So basically this case, patient has just 1, 2, and 3 teeth in contact for her posterior teeth. Definitely, she could not chewing. One of the main problem is that when we try to create the occlusion for the patient, when you were undergrad, we teach you that it has to be a cast to fossa, cast to marginal ridge. This thing could only happen when your teeth have a full anatomy. When your teeth have a full anatomy, you can create what we teach in the dental school. But in reality, after your teeth has been worn out, because patient is like 50 something, her teeth has been worn out according to the previous position of her teeth. After we align it, put it in a new position, make them align nicely. The teeth that has been worn out already, that could not be in contact. So we realized that the main problem is because of her occlusal anatomy is gone. Then what we need to do is we need to put occlusal anatomy, put the groove, put the cast back to make it in contact. This one is show that her tooth alignment is off. At the beginning, I asked her that if you want better occlusion, you need a full mouth rehabilitation. Yeah. But she denied that. Cost of full mouth rehabilitation is too much for me. I want to save money for my kids. They are in college. I cannot afford that much money. So we have to do something more compromise for her. Then I decided that I will only restore her lower teeth. Restore her lower teeth to make in occlusion. And we will use only the direct composite for her because that's a lot cheaper than indirect restoration. Then we start mocking up. We start mocking up in the digital. It's called digital wax up in the software to make it in contact. This is the beginning, before, and this is after digital wax up. After I take a look and I check with the lab, we make a few adjustments and ask them to 3D printing of the lower model, this one. This is the final design that I approved with them. And then 3D printing model like this. This is what we want at the end. Then we use some type of the clear PVS to copy the anatomy that we want. We use clear PVS to copy anatomy. Then we drill some hole into the clear PVS like this. And then we use some type of, it's called injectable composite. It's similar to a flowable composite, but high filler load. So it's strong enough to stay on the patient tooth, even on the occlusal posterior teeth. And this is after I put the composite on her teeth. You will see that this is before and this is after. And this is how it ends up for the patient on the both sides. Let's put the picture for comparison. The upper one is before, this is after, this is before, and this is after. Because of the digitally assist, you create all of restoration for her all lower posterior teeth, 8 teeth. Everything has been done in just one visit. Just one visit, and patient can going home with the teeth. Now she can chewing. And now you got a happy patient. Okay. Okay, this is summarized before or after orthodontic treatment and restoration to restore her occlusion. Okay, let me skip my last case and go to the summarize. Challenge and benefit of using the future direction. Because this one, most of them, it used in the computer. For the dentist who has been practiced for a very long time, when you have to throw it away, something you practice for your whole life and start a new thing, it's not easy. For the younger generation, when they start from zero, when they start from scratch, it's easier because they have nothing to lose. But for us, I use PVS for like almost 20 years, and then I have to throw it away, go for the digital. And when we're getting older, we utilize software, we learn something new harder. That's why for the who is become a specialist already, who practice for a really long time, it's very hard for them to adaptation to a new technology. But everything you have to start. It's saying that when you plant a tree, the best time is 10 years ago. The second best time is today. So you're supposed to learn, you have to embrace it, the technology. You have to admit that the world is moving and shifting into this way. You cannot just sit still and you say that, oh, this is good for me. Because in the future, very soon, the younger generation will come up with a new technology, which patient has more comfortable. They can work faster. Patient can perceive everything right before. So you have no choice. You have to embrace it. You have to admit it. This is our future. Plus, even right now, AI has a tremendous role in our dentistry. Some company right now, they launch AI for dentistry already. Everything I teach you at the beginning, where the teeth is supposed to be, the height, the width, right now AI can calculate it and generate it already. Even it's not as good as we did it right now, but it's in the process to improve. So it's coming very soon. Then you have to admit that. Let me show the last video. I think this one is good and nice. I want to show you. This is the power of a
I remember
digital.
in the early days of school, I was an Olympic student at math. That lasted one semester. The following semester, I was flunking the class. This didn't happen because I suddenly didn't understand math anymore, but I failed to understand the application of it. It was just a mind game with no real meaning, and at that age, you can find much more interesting games. So I stayed away from it, and I became a dentist. And ever since, I pursued aesthetics and understanding beauty. 15 years later, I learned one very important lesson. At the core of aesthetics is shape. Shape is geometry, and geometry is mathematics. In a digital world, this was a huge game changer for my mind. Nature is an unlimited library of designs, a library of natural beauty. It is DNA in mathematical form. Every tooth, every shape, every texture nature ever created is uniquely beautiful. And today, we can copy it. Don't get me wrong, nature will always be one step ahead. Like every ideal, you will never reach it, but you will find fulfillment and greatness on this journey. It will always be like chasing the stars in the night sky. We will never reach them, but they helped us navigate the seas since the dawn of man.
Okay, lastly, I will thank you all of you guys to come to my presentation. I will thank you all of my colleagues and my students. Without them, I would not able to be here. Thank you. Terima kasih.
Thank you very much. Thank you very much for your lecture, for your insightful and informative lecture. We have listened to his lecture about the digital smile design and how to determine the tooth proportion and how to make to increase the bite height and how to make a mock-up and the use of the digital technology with the intraoral scanner and etc. I think now we go to the Q&A session. Now we open for a couple of questions. Please feel free to ask whatever you want to ask or to know more detail about Dr. Chachawit's lecture. Any questions from the floor, please? Don't be shy to ask. Maybe I want to ask a few questions to Ajahn Chachawin.
Yes.
ขอบคุณครับ about the use of your digital scanner. Does the program only works with a 3-chip from Trios, or it still can work with other digital scanner?
You can use any digital intraoral scanner to digitalize the information. But if you want to do the smart design, you can do it either manually by using Keynote and PowerPoint as I show you. But if you want to make your life easier, there is a prefabricated software. They can manage your whole thing easier for you. 3Shape is a nice one. And even the DSC program from Christian Kochman is also good. They're also available from the Ivoclair, from the Strawman, a few companies that you can use it. So you don't need to use the Trios. You can use any intraoral scanner.
And then during the cementation of the veneer or crown, will you go to the preheated composite or will you go for the resin cement?
Sorry?
I mean, for the cementation of veneers or other indirect restorations.
What kind of cement I use?
Yes.
Right
Will you
now,
use the preheated composite or the resin cement?
I use a resin cement. Right now, I use a light heel. Resin cement is Panavia B5 LC. The light heel and clear cement. Actually, there is another big topic about how thick it is of the material we use, what kind of material we are going to use. Because right now, patient wants something look nicely, aesthetically, and translucency. If we use translucent material and the patient have a graded teeth or darker teeth, you may need to increase the thickness of your restoration, or you have to change to something more opaque. That's it. You have to negotiate with the patient right before your preparation. You have to plan it at the beginning, but you can do it. Yes.
And then during your mock-up with those direct composite, injectable composite to increase the vertical dimension, will it be permanent restoration or just a long-term provisional?
That one is called semi-permanent because composite is a high filler load. That one is not a mock-up.
But how if some days it breaks or deform? I mean that flowable composite, the injectable.
Injectable is not it looks similar to flowable but have a lot more filler load. So it's strong enough. You can use even for the small class 2 occlusion. And this one actually I proposed to do the full rehabilitation because of her financial reason. So I asked her that, okay, if this is what you could afford, is it the most you can pay for? I can do this for her. But she acknowledged that at the beginning, this one is not like perfect treatment. It's somewhere like it's called interim restoration. When she's ready, she can coming back. But according to this case right now, I did it for like 8 months ago. She is totally fine with that. No breaking, no shipping for 8 months.
Great.
Yeah.
Any other questions? Any question from the floor, please, from the audience? And I'm also interested in your topic about the AI because one of my studies is also about AI. What do you think the AI can give biggest contribution in the future of the digital dentistry?
Right now, Trios company, they propose the AI design already. You can just input your information, you can submit your case to them, and they use AI to design digitally for you. Right now, even you use a digital software, you still have to know that where you want to put the teeth in, how long it's going to be, is help you make your life easier. Still, you need to know that everything information I give at the beginning, maybe a little bit boring, but it's essential. But for the AI, they include all of that information into the software already. So they will propose you and they will give you a choice. You want something like this, or like this.
It's just the advancement of the deep learning of the
Exactly.
AI, more automation.
Exactly,
Yeah.
It's more automation.
Yeah. Thank you very much.
And even not only in the field of restorative dentistry, right now AI and the robot can place an implant already. I think you saw it already. They use a robotic with AI to place an implant in the real patient. Even it's not like in commercial yet, it's in the case study, but it's happened already.
Maybe one day, the robotic can do the prep.
You know what? It's happened already.
Yeah.
They use a robot to do a tooth preparation already. But as I told you, it's still it's called in the experiment study, not in commercial yet. But it do exist. It's happening. It's not future anymore. You just have to waiting when it's available for general dentists for most people.
No questions? If no question, then I think we can finish this session because of the time constraint for the next session of lecture. And let's give big applause to our speaker, Dr. Chawin Bungorasawaporn. Thank you very much for coming. ขอบคุณมากๆ And I give back to the MC.
Thank you to the speakers and to the moderator.
Next on, we would like to present the certificate to the speaker and moderator given by Dr. Gigi C. Daramanja, SPRKG Subspesialis RDP Konsultan, to Dr. Dara. Time is yours.
Once again, please give an applause to our doctors. Okay, without further ado, let us continue to our next seminar with Trinette C. Colina DMD, MHPED, with the title Strip of Crowns Medici for the General Practitioner.
With moderator Dr. Gigi Tanti Deryati, MDSC, SP Ortho Subspesialis DDTK Konsultan, to Dr. Tanti, time is yours.
Okay, thank you MC for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all attendees. We are now going to begin the next session with the topic strip of crowns made easy for the general practitioner, which will be presented by Trinit C. Colina, DMD MHPED. Before presenting the lecture, allow me to read the CV of the speaker for this session. Trinit C. Colina, DMD, MHPED, works at Pediatric Dental Consultant, Headway Qualimed Hospital, Rosa, Novelli North, Santa Rosa, Laguna in 2024 until present. As clinical instructor at Adventist University of the Philippines, College of Dentistry 2024 until present, 2013 until present, Assistant Professor, University of the East College of Dentistry, 2023 until present, Pediatric Dental Consultant, CM Smile Dental Center, 2023 until present, Peer Reviewer, Journal of Global Oral Health, Clinical Supervisor on Pedia Ortho Section. Now, we will invite the speaker to deliver the presentation. Let us welcome Trinit C. Colina, DMD MHPAD.
Okay, thank you very much for the very kind introduction. So this is the title of my topic this afternoon, Strip of Crowns Made Easy for the General Practitioner. So again, hello, I'm Dr. Trinette. I graduated from the top dental school in the Philippines, the University of the Philippines, Manila, College of Dentistry. And this is what we look like during graduation. So currently, I'm an assistant professor at one of the universities, University of the East, Manila. And another one is the Adventist University of the Philippines, from which I've been a part of since this year. So again, I'm a pediatric dentist, and this is my main place of work, which is Healthway Qualimed Hospital, Santa Rosa, Laguna, Philippines. So before I start, so I have no financial disclosure or conflicts of interest with the materials in this presentation. So let me go to my outline. So this is not too long, so as not to bore everyone. So I'll give a short introduction about strip of crowns. This morning, Dr. Amy Angela was able to discuss about crowns in general. So I will be doing a follow-up on that. Okay? So I will be showing you a case also, okay, and the step-by-step procedure. Okay, let's start. What are strip of crowns? So if you read journals, you can see not just strip of crowns, but also read it as strip crowns. Also, this morning, when Dr. Amy Angela delivered her lecture, I realized strip of crowns might not be familiar to you because they're also known as celluloid crowns. So that's just the same. Okay? So it's the most popular type of preformed aesthetic crowns for primary incisors. Okay, it was first introduced in 1979 by Weber. So this was like 45 years ago. So what is the challenge for strip of crowns? So actually, there are not a lot, but only a few long-term controlled clinical studies about it. And one very important consideration nowadays is the concern for aesthetics, its impact on restorations. So as what we heard from the lecture previously, aesthetics using digital dentistry. So that's why even the theme of this conference is enhancing skills and knowledge in aesthetic dentistry, because aesthetics is very important nowadays. Do you agree? Yeah. Okay, I'll show you one study. Okay, this was by Pani and colleagues in the year 2016. So they wanted to compare the opinions of children aged between 5 to 8 years old and the opinions of their parents regarding the appearance of teeth. Some because of dental caries and also the materials used to restore these teeth. So they gathered 107 children, including both their parents, the mother and the father. So that equals to 321 respondents. So they concluded that there is no difference in responses between children and their parents. So what does it mean for us? Even children as young as 6 years old actually are capable of appreciating aesthetic restorations. So, after establishing the aesthetic concern, let's ask this question. What age do our maxillary incisors and canines shed? So, for our maxillary central incisors, it's around 6 to 7 years old. For maxillary lateral incisors, that's 7 to 8 years old. And for our canines, that's 10 to 12 years old. So what is the point of me asking you this? So I wanted you to realize how long will these primary teeth still stay inside the patient's mouth. Okay? So when you give this option of treatment to the parents, you can include this and say that it will take a while before these teeth will shed. Next, let's go to indications. But before that, this picture is not actually my photo. I usually do teledentistry. So when I say teledentistry, that's doing video consultations or video calls with parents and their children for an initial consultation. So I liked using it, and maybe you might consider it also for your own practice, because parents can have earlier appointments because it's a video call. They don't have to get a schedule for your clinic or make sure that you are in the clinic. Okay. Of course, there are limitations. No? So this photo is actually a photo sent to me by the parent. Okay. So I'm able to do an initial diagnosis. I'm also able to give a treatment plan and also give the management and the estimate cost of treatment. Okay? So it makes it faster, but it's not a guarantee that parents would bring their children back. So sadly, in this case, in this photo that I showed you, the photo came from the parent, but they did not push through with the treatment. Okay. So, but let's use it and see if it's indicated for strip of crowns. So number one is multi-surface caries. So when we look at the right and left central incisors, so yes, we have multi-surface caries, labial, lingual, incisal, mesial surfaces. Second is if the incisal edge is involved. So we see that also here, class 4 caries. When we have extensive cervical decalcification, so for those with class 5, in this case, it's not. When we have pulp therapy procedures such as our pulpotomy and pulpectomy, our final restoration for anterior is a strip of crown. When we have minor caries but poor oral hygiene, we do recommend strip of crowns as well. Also, if there is difficult moisture control because of the child's behavior, we also recommend to use strip of crowns. So with all of these indications, most likely you will have one which will need strip of crowns for your patient. Next, let's go to the advantages. So I have two. One is that it is highly aesthetic. So later I'll show you some photos, okay? So because to see is to believe, right? And second, the fabrication and placement usually will not need local anesthesia. So I think the use of local anesthesia is one of the things that children are fearful of. Okay, next. Of course, if we have advantages, we also have disadvantages. It is technique sensitive, okay? And possibly, if it's your first time or even second time, you might need a lengthy treatment time. So meaning it will take a little bit more practice for you to get used to. Second, the proper retention will depend on adequate tooth structure left after caries removal. And last, strip of crowns are not for patients with deep bites or anterior cross bites. So what are the challenges? So this is another case that was sent to me by the parent. So I usually include photos. I ask them to send photos so that I can more or less gauge and assess the child's case. One is a small size of teeth. So, of course, compared to permanent teeth, we have smaller size of the primary teeth. Therefore, we also have relatively thinner enamel and also thinner dentine, which can also lead to possible pulpal exposure if we are not careful. So another challenge is it being close to the pulp. Okay, and last but not the least is the child's behavior. Okay. So this is actually from the study of Wagoner in 2014. So as general practitioners, what are our concerns? One is the behavior of the child. Okay, so in this photo, this is my patient. So I usually have them strapped in a papoose board. And the cell phone is not my idea. It's from the parents. So the parents even brought their own clip. No, I'm not an advocate of the use of cell phones or gadgets for patients, but the parent was insistent. Okay, so I let them be. But I usually use papoose board. So this is a strap for the arms and the body. So the body has the upper part, the middle part, and the leg part straps. Okay. So another is the behavior of the parent. Okay, so one important consideration is you want the parent to agree to your treatment plan, to your use of strip of crowns. So why did I say behavior? Because if they do not agree, that is a concern also of you, right? Because you'll not be able to do your strip of crown without the parent's consent. And last are the materials and equipment. So this one, I think we can easily control, right? The first two, probably not. The behavior of the child, the behavior of the parent, both which are unpredictable. Okay? So later, I will show you the materials and equipment that we will be using. So what do studies say? Okay, so I mentioned a while ago that there are few long-term studies about strip of crowns. Let's look at one. So this is from Kupiecki and colleagues in the year 2005. So all of them are diplomates of the American Board of Pediatric Dentistry. So they studied 145 strip of crowns in 52 patients. So on average, 31.3 months, or roughly 2.5 years, the strip of crowns were in place, meaning they are inside the patient's mouth and functional, before they did the evaluations by 2 independent evaluators. So this is from their study. So we see 4 strip of crowns for our maxillary incisors. So we have the laterals and the centrals. Okay, so we see the right central incisor, which has a large loss of crown material. The left central incisor also has loss of material, but not as much as the right central incisor. Whereas our lateral incisors show no material loss. Okay, so what did they conclude in their study? It's not 100% retention rate, okay, but only 80%. But even with 80, I think 80 is good enough, right? 80% is high, okay? And actually, there's no or 0% total loss of strip of crowns. Okay? So if this doesn't convince the parent yet, you can also mention this. 83% of the cases retain for 1.5 to 2 years. It's still a high percentage, right? And 78% retained for more than 3 years. That's a good number of percentage. Okay, so another case that they mentioned in their paper is this one. These 2 central incisors, okay, the right and the left, were rated after 48 months. That's what? 4 years. Wow, right? Okay. So this one, the right one, if you look at it, it was rated A in all clinical aspects. It's pretty good, right? Whereas here, the left one is rated as B, according to gingival health, the contour of the crown, and there's a bit of loss of material. Okay? That's why it's only rated as B. But we see that there is very good color matching. We also see very good color stability, right? 4 years is not a joke. It's a long time. And we have very good, acceptable clinical crown contour. How about radiographically? So 92% have healthy pulps, and that is a high percentage also. Only 6% had some pulpal changes, which do not require immediate attention. And only a small number, 2%, had pulpal pathology. So what are the hashtag goals, okay, mentioned in this paper? So first is to functionally and aesthetically retain the primary teeth. So when you discuss it to the parents, the goal is not only for it to be aesthetic, but also for it to perform its function. Okay? And second, the goal is natural exfoliation, wherein no retreatment is going to be done and no pulpal complications. will happen. So another study, okay, so another long-term clinical study is from RAM. So this was in the year 2006. So this assessed the longevity of our resin-bonded strip of crowns. So actually, they studied more strip of crowns, 631, and more patients, 200 patients. So they did this study for 2 to 4 years old, okay? And the follow-up was done for at least after 2 years. So actually, their results were similar to Kupiecki's study, that more than 80% were successful based on color and texture, the clinical appearance, and the like. Next, let's go to my case. So this was a patient referred to me. So originally, this was not my patient. The patient came in with several things done already, meaning it's not a fresh patient. The medical history was unremarkable, but the patient has a behavior management problem. So usually I get cases that general practitioners cannot handle because the patient is already crying, doesn't want to sit on the dental chair, okay, those things. So the dental history was that 3 months ago, the patient had oral prophylaxis, several composite restorations, and also, surprisingly, the general dentist cemented anterior acrylic crowns. So when you look at it closely, the canines are 2 single crowns, whereas the lateral and central incisors are connected to each other into an acrylic bridge. So the dentist, the general dentist is my friend. So I cannot say, why? Why did you place acrylic crowns on your patient? Anyway, no, I did not want to dwell on the why because it's there already. It happened already. Okay. So what we did was we got clearance from the pediatrician because we wanted to do the procedures under intramuscular and intravenous sedation by the anesthesiologist. So here, in the photo, the intravenous was being placed already. So I still use my papoose board to strap on the patient, even if the patient is sedated. Okay, fast forward, I did the stainless steel crowns. What is remarkable about this case is that the 6 anterior strip of crowns were made by the general practitioner. So what do I mean by that? So the parent, the father, requested that the general dentist should be the one to do the strip of crowns because she was the one who did the acrylic crowns. So I said, okay, that's fine. So I, of course, since she's my friend, I helped her do the strip of crowns, meaning I guided her, okay, on the step-by-step procedure. So I think when we look at the finished case, it's not that bad, right? Although actually she was telling me, why do we have spaces? I actually wanted the acrylic crowns. I liked it because there are no spaces in between. Then that made me think, she's used to aesthetics for adult patients. Because for adult patients, you don't want any spaces in between your teeth. But for primary teeth, these spaces are actually good and they don't look bad. It's natural to have spaces in between teeth for the primary teeth. Okay, next let's go to the procedure. I mentioned a while ago that we will be enumerating the materials and equipment. So recently, I did a workshop on strip of crowns. It would be good actually for us to have it also here, but maybe on another time if I get to be invited again. Okay, so let's go through it one by one. First, sharp curved scissors. So it's this one. Next, composite filling instrument. It's this one. Our basic instruments such as mouth mirror, dental explorer, our cotton pliers. Our restorative burrs. Okay, I hope you see this one. This is our strip of crown. Our etchant and bonding agent. Our A1 packable composite here. And our light cure unit over here. Next, let's go to the step-by-step. First, we have to decide, should we anesthetize or not? So I mentioned a while ago, one of the advantages is that you can opt not to anesthetize, especially if caries is not deep, meaning there's no probability of it reaching the pulp. You can choose not to anesthetize. You can just place your topical if you want. Next is the tooth preparation. So these are the burrs, the set of burrs that I usually use. These are diamond burrs. Okay. So when we do the tooth preparation, first we remove caries. Okay. And then we make sure there is an incisal clearance of at least 1 millimeter. Okay? So after caries removal, before you reduce the incisal, check first. Maybe after caries removal, you already have this 1 millimeter of clearance. So the reason for this clearance is you want it to be composite later on. You want at least 1 millimeter of composite to be at the incisal edge. Okay. Next, make sure you have proximal clearance. Okay, you just want to make sure there's no you just want to make sure your strip of crown will go in the proximal. And also, unlike your porcelain fused to metal, which is shoulder and chamfer margins, we use knife edge or feather edge margins. What do we mean when we say knife edge? So it's like having no margins. There is no ledge, unlike your shoulder margin, or unlike your chamfer margin. So it's just straight, okay? So maybe you will see something like this, the preparation, okay? Next, I like choosing my strip of crown next. Okay? So I usually don't prepare the strip of crown in advance because I always tell my students, what if the patient does not come? You already cut your strip of crown. What will you do with the crown? Right? It will be a waste. Okay, so I like to do the strip of crown preparation after caries removal, after I prepared the teeth already. Because even if it's a private practice, we're also not 100% sure that the procedure will push through. Okay? So choose the correct size. Okay? So usually, strip of crowns, when you buy strip of crowns, it's a set. Okay? I'm not sure if we have it with the trade exhibitions. No? Later, I will have a look. Okay? But these are from sizes 1, 2, 3, and 4. Okay? So the millimeters here is the mesiodistal width of the tooth. So if you don't want to buy a set because it's expensive, especially this brand is expensive, you can actually buy a few pieces, no? Probably like 2 per size, no? And have it in stock in your clinic. So when you measure the mesiodistal width of your patient's teeth, that's when you can decide on the size. So we have here for the lateral incisors, we have here for the central incisors. So on its own, it looks something like this. So it has this cervical tab that you can easily hold the strip of crown. And even if you remove it from the set, you will still know the size and the tooth. So the number here is the size, 1. This one is 2. Okay. This one is A in Palmer's notation. So this one is at the right side. This one is B, and it's on the, what's this? Right side also. Okay. So this one is what you will cut later on. So here, I just got this from the website. So this specific brand has these sizes, the mesiodistal width of the sizes. Okay? So of course, other brands would have different way on how they do the sizing. So other brands don't have the 1, 2, 3, and 4, but instead have the mesiodistal width as the sizing. Okay? So again, you cut after you choose the correct size of the crown. Make sure first 100% it's the correct size, because after you cut it, you cannot put it back on your set, right? Okay. So you cut here at the cervical area. For sure, it will be long because that is to accommodate the different anatomy of teeth of patients. After you cut, you can place your vent holes. I like placing it at the incisal angles. So use your explorer, punch holes from inside to outside. So be careful, you can use your cotton here so as to prevent accidents. So I like placing 2, one at the mesio-incisal and one at the disto-incisal angle. Okay, so later I'll show you a photo and we'll explain why. Next, we check the fit. So this was the same photo a while ago. So actually, if you notice, there's no holes yet. You can also check the fit without the vent holes yet. Okay, so that when you take a photo, there's no hole here. Okay, but you check the mesiodistal inclination, the labiolingual inclination, before you decide that this is the final already. So here I placed the arrows on where your vent holes should be. Okay. So when you read books, some would say you place the holes at the lingual part. And actually they just say to place 1 hole. Okay, that's fine also. But later I'll explain why. Why I like putting it here and what makes it easy for the general dentist. Next is the final restoration. We fill the strip of crown, 2/3 of your packable composite, incremental. Okay, so place it in increments. You push it against the strip of crown to make sure there are no bubbles, no air bubbles. Then you etch, wash, and dry the natural tooth. You place bonding agent, then you cure. Then, of course, you insert already your crowns. Do a final check. What's the final check? So before you cure it, make sure it's the correct inclination, mesiodistal, labiolingual. You're satisfied with it. But of course, do not take too long. Okay? So sometimes this is the step that clinicians find it difficult. Okay? Don't take too long. Okay? and then you cure it. Okay, so next is you strip it off, and that's the reason why it's called strip of crowns. So if you remember, I mentioned placing vent holes here at the corners. So since there are vent holes, the excess composite will push through there. Okay? So what do we do when it's cured already? We reshape it. The excess are like blobs of composite. Okay? So we reshape it by using our burr, our finishing burr. We round the distal angle, distal incisal angle, and make here it's more sharper, the mesio-incisal angle. And then I like also to reduce a little bit of the incisal. So why? Because when I strip it off, I like to strip it off from the incisal, labial, and lingual. Okay, so if you read books again, they would say use your instrument. Okay, at the cervical area, I don't like because your instrument can cause damage to the gingiva and it will bleed. Some would say, anyway, that's the lingual. Use your instrument at the lingual. I cannot see. It's indirect vision. I have to use my mouth mirror. It's more difficult. But when I do the labial portion, when I trim the labial portion, I can see it, direct vision. Okay? When I strip it off using my explorer, labial, lingual, I can see it directly. That makes it easier. Okay? So when your composite resins polymerize in contact with plastic, like your celluloid strips, they have the smoothest possible finish. Do you agree? Right? So it's similar to the use of celluloid strips. That is why we use strip of crowns. So also, it prevents composite staining. So as much as possible, we do not finish the labial anymore. If we trim the incisal to reshape it, I don't think there is a need to polish the incisal anymore, right? So no finishing of the labial surface is needed. Okay. So of course, you give your post-op instructions, your post-operative instructions regarding food. You have to inform the parents that strip of crowns are not as the strength is not the same as a natural tooth. Okay? So I think that's one of the important things to take note of. So again, we look at the before and the after. Okay? So I think the parents are very happy about it. No? I wanted to add another photo, hopefully after the gingiva has healed. If you notice, we have a lot of plaque in the before photo. That is why after strip of crown placement, the gingiva is still inflamed. Okay? So lastly, we are wrapping up. Please look at your seatmate. Tell him or her one thing that you have learned today and how will you apply it in your own practice. Okay. Thank you, everyone. Connect with me. This is my WhatsApp, my email address. Share to me your cases. I would love to hear about your cases. Thank you very much.
Thank you, Dr. Trinit, for a very interesting presentation. Now we will open a question and answer session. If you have any question, you can raise your hand and discuss it with the speaker. Okay, any question? Dr. Trinit, if I may, I want to ask a question. Previously, you mentioned indication of this strip crown How about the contraindication? Is it only not for deep bite patient or any other contraindication?
Yes, so it's not for deep bite and those patients with anterior crossbite. You have to assess also the remaining tooth structure. Now, of course, there is no one strict number, no, with regards to the remaining tooth structure left. And before you do caries removal, you have to assess first, is it restorable or not? Okay. Yeah, I think that's it. You have to decide first, is it restorable or not? Sometimes, especially in the previous case, there's caries, but it's arrested. No? So if you think, should I still remove arrested caries because I don't want the dark colored caries showing through my strip of crowns? So I think since it's arrested, you don't have to remove it. And that's valuable tooth structure, which is needed for your strip of crowns. Always remember your strip of crowns are bonded. So the lesser tooth structure left, the lesser surfaces, which can be bonded.
Okay, thank you. Maybe any other question? Maybe from front seat? Any other question for Dr. Trinit? From back seat, maybe? Okay, Dr. Maya?
Hello, Dr. Trinet. Nice to meet you. I'm Dr. Maya. Just one simple question I want to ask for you about. Would you explain to us about the material as a filler? Yeah. You explained to us the crown, but you not explain the material, the filler material. What kind of filler material you use?
Okay, do you mean the...
How about the material strength? Yeah, thank you.
Okay, thank you for your question. Do you mean the material of the strip of crown itself?
Yeah. No, the filler.
The filler, okay.
Yeah.
So the composite.
Oh, it's
Okay,
composite.
yeah, it's composite. So it's the usual composites that we use for our patients. Packable composite.
How about the strength? If we compare with stainless steel crown, is it more better or not?
Okay. Stainless steel crowns are better. So if you were here from the lecture this morning, I was able to catch Dr. Ami Angela's lecture. So she mentioned that stainless steel crowns are still the gold standard. But nowadays, it would look funny for a child to have a stainless steel crown in front. But actually, manufacturers do have stainless steel crowns for the front teeth, if you do prefer stainless steel crowns. So comparing it to stainless steel crowns, the strength is better for stainless steel crowns. Again, for strip of crowns, since we use composite, it can fracture. That is why you have to give your post-operative instructions. Okay. Also, Dr. Amy Angelo mentioned the use of Bioflex, zirconia crowns. Those are aesthetic crowns also, but they also have the same problem, chipping off. So I think this material is something which is more affordable for the patient and for the general dentist. I hope I answered your question, Dr. Maya. Thank you.
Thank you, Dr. Trinit. Any other question from the audience? Okay, maybe one last question from me. Is it any retention problem you found in your strips crown case? and how to solve it?
Okay, so in my cases, usually none. But of course, it's not because I'm perfect. It's because sometimes the problem in the Philippines is that patients are lost to follow up. So I would like to believe it's not because I'm perfect, but hopefully there's nothing wrong. That's why these patients do not come back. Almost always, patients would come back if something is wrong again, no? So that's my answer. Thank you.
Thank you, Dr. Trinit. Due to the time constraint, we're sorry that we have to end this session. I'd like to thank to the speaker for informative presentation and all the participants who have attended this session. I think that's all from me. I'm giving back to MC. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to moderator and speaker for this seminar session. Next on, we would like to present the certificate to the speaker and moderator given by Professor Dr. Gigi Sondang Pintauli, PhD, FIS, DPH, FIS, PD, to Prof. Sondang. Time is yours.
Okay, once again, please give an applause to our doctors.
Kepada seluruh peserta seminar, dipersilakan untuk menikmati hidangan coffee break yang sudah disediakan sebelum kita masuki seminar sesi terakhir pada sore hari ini.
To all the participants, are welcome to enjoy the coffee break snacks before we continue to our last seminars today. Thank you.
Cheek. Cheek.
ini kalau misalnya mau sambil jalan boleh dong kalau
Enggak deh.
ini.
Enggak usah jalan-jalan. Mager. Ditutup aja, di off kan aja. Kalau ini bisa.
Today I don't feel like doing anything. I just wanna lay in my bed. Don't feel like picking up my phone, so leave a message at the tone. 'Cause today I swear I'm not doing anything. I'm gonna kick my feet up, then stare at the fan. Turn the TV on, throw my hand in my pants. Nobody's gonna tell me I can't. Nah, I'll be lounging on the couch, just chilling in my snuggie. Click to MTV so they can teach me how to Dougie. 'Cause in my castle, I'm the
Biar kadang aku baca dari sini.
Kalau ini
Oh iya. Oke. Oh iya.
I don't feel like doing anything. I just wanna lay in my bed. Don't feel like picking up my phone, so leave a message at the tone. 'Cause today I swear I'm not doing anything. Nothing at all. Nothing at all. Tomorrow I'll wake up, do some P90X, meet a really nice girl, have some really nice sex, and she's gonna scream out, "This is great." Yeah,
Kalau
I
untuk ini,
might mess around and get my college degree. I bet my old man will be so proud of me.
kalau lasernya mana?
Pop your head away.
Oh, pantesan. Oh. Ya, nggak apa-apa, nggak usah weh. Kalau perlu. Iya.
I just wanna lay in my bed.
Oke.
Don't feel like picking up my phone, so leave a message at the tone. 'Cause today I
Ruangannya
swear
digelapin
I'm
dikit
not
nanti.
doing
Tadi
anything.
shiny. Iya, terima kasih.
Oh, I ain't
Rewel.
gonna comb my hair, 'cause I ain't going anywhere. No, 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 no. I'll just strut in my birthday suit and let everything hang loose. Yeah, 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 yeah. Oh, today I don't feel like doing anything. I just wanna lay in my bed. Don't feel like picking up my phone, so leave a message at the tone. 'Cause today I swear I'm not doing anything. Nothing at all. Nothing at all. Nothing at all. Cause I'm in the stars tonight. So watch me bring the fire, set the night light. Shoes on, get up in the morning, cup of milk, let's rock and roll. Kink out, kick the drum, rolling on like a rolling stone. Sing song when I'm walking home, jump up to the top of the brown. Ding dong, call me on my phone, nice tea, and I'll get my ping pong. This is dead heavy, can't hear the bass, boom, I'm ready. Life's sweet as honey, yeah, this beach treat like money. This go all alone, I'm into that, I'm good to go, I'm diamond, you know I glow up. Hey, so let's go.
Okay, without further ado, let's take to our last seminar today with Dr. Gigi Yuli Nugraini SPKG with the title Potential of Malic Acid from Aloe Vera for Tooth Whitening.
With moderator Dr. Gigi Nevianti MKS SPKG Subspesialis KE Konsultan. To Dr. Nevi, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Selamat sore. Masih bersemangat ya, mudah-mudahan udah kena kopi dan snacknya. Sebelum saya mulai, izinkan saya berpantun, tapi tidak dalam bahasa Inggris, dalam bahasa Indonesia saja. Nanti bilang cakep ya, gitu ya. Jangan didemin aja, jangan dikacangin. Soalnya nih lumayan mikirnya 2 jam tadi. Kalau mau ke pangkalan susu, harus melewati Idcsu.
Cakep.
Selamat datang di Idcsu.
Cakep.
Semoga pulang bertambah ilmu.
Cakep.
Oke, ini yang paling mendebarkan, saya harus berbahasa Inggris. Mohon maaf kalau saya punya pronunciation sangat bagus sekali, nanti agak pusing mungkin mendengarkannya. Oke, thank you MC for the opportunity given. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Afternoon apa evening ya? Ya, sim lah. Gitu. We are now going to begin the next session with the topic of Dr. Yuli Nugraini with the title. What title? Tadi sudah disampaikan ya dok ya, titlenya ya. Ya. Potential of malic acid from aloe vera for tooth whitening. Before presenting the lecture, allow me to read the CV of the speaker for this session. Dr. Gigi Yuli Nugraini, spesialis konservasi gigi. Beliau, bahasa Indonesia aja ya. Beliau lahir di Surabaya tanggal 22 Juli 1969. Saat ini sebagai dosen di Universitas Brawijaya Malang, lumayan jauh. Oke, tanpa waktu banyak apa sih dok namanya menambah waktu, kami persilakan, please Dr. Yuli to present your presentation.
Okay, thank you, Dr. Nevi as my moderator. Oke, assalamualaikum warahmatullahi wabarakatuh. Selamat sore, salam sehat dan sejahtera. Now the session, the ending of session ya, and before this, thank you for the invitation. Yeah, that's why I coming here from Malang. Yeah, it's far away from here. Takes a bit 4 or 5 yeah, by flight. Okay, now I will share about the terms of the in silico approach. So, as we know, the in silico research is conducted using computer simulation, data analysis, or mathematical modeling to study biological, chemical, and physical phenomena. So this method relies on software and algorithm analyzed to simulate complex system without involving direct experiment in the laboratory, yeah, like in vitro or in vivo. So this is more practice ya, lebih praktis. Okay, I will begin with the here. Cannot. Why? The committee, please. Why I cannot put? Oke. Oh, nextnya di sini. Oke.
Kalau untuk nextnya ke bawah, Bu.
Yes.
Balik
Okay.
lagi.
Yeah. Okay, I want to share about the herbal tooth whitening. Yeah, as we know, the tooth bleaching is a technique that whitens teeth by oxidizing the enamel surface. So we know the carbamide peroxide or peroxide compounds are an effective ingredient usually used in dental bleaching. And the previous study or the theory, is the old theory, said the peroxide compounds can cause the tooth sensitivity. So in our study, developing new method using natural ingredient that achieve similar cosmetic result with fewer side effects that would be highly advantageous. We also know the natural ingredient for dental bleaching, in the outside of marketplace, we can see the lemon, apple, rosella, green pear, and all of them contain the malic acid. And this is a study, previous study is a systemic review that I write with my team. The title is Potential Malic Acid from Aloe Vera for Tooth Whitening. Anyway, the presence of high concentration malic acid in aloe vera, this is 18.17%, followed by acetic acid and citric acid in aloe vera gel. And the previous study also said that there is a significant difference in hue, chroma, and value in the color of the shock and plant juice containing malic acid. And also the malic acid plant extract could reduce the stain of the teeth. That is mentioned by Hardini et al. So the effectivity of malic acid, or we call the Z-2-enidoic acid, this is the plant pure containing malic acid remains less effective as whitening compared to conventional 35% carbamide peroxide. Then 10% carbamide peroxide of bleaching agent was more still effective to compare to soaking in 100% plant extract containing malic acid. But in limitation and suggestion, we have clinical and follow-up protocols employed across the included studies are still limited. And the use of malic acid from different plants and method complicates the comparison of the result. Therefore, still need to establish standard experimental protocols to improve data consistency and interpretation. And also the further study are still need to determine the optimal concentration of malic acid from aloe vera for tooth whitening. In this study, the objective is to predict the physicochemical properties, pharmacokinetic, drug likeness, and potency of Z-butanoic acid, or we call it malic acid, as a TRPV4 inhibitor. So the outline of the study, yes, this is introduction, is ini. material method, result, and also discussion, and also conclusion. So in the introduction, as we know, the tooth bleaching of the natural, the tooth bleaching is removal of dental stain using oxidizing agent. We call hydrogen peroxide, as I mentioned, and carbamide peroxide. So this oxidizing agent can diffuse through dentinal tubuli, can cause the tooth hypersensitivity. So how about this? Tooth bleaching cause patient discomfort. Yeah. So our study explored the compound of the Z-but2 anidoic acid, and then we suggest that malic acid or Z-but2 anidoic acid may inhibit the TRPV, which is nociceptor receptor. Okay, what is the TRPV exactly? Yeah, we know that TRPV is a transient receptor potential channels, or TRPV is the group of the natrium permeable non-selective cation channel that required for transmitting somatosensory stimuli, including itch, pain, temperature, and mechanosensation. This molecule is considered the primary molecular sensor of sensory nerve afferent nociceptor. So TRPV4 is one of the types of TRP channel that function to receive chemical stimuli. This study about the material and method, as I said, with the in silico approach. Yeah. The protocol or the step of the in silico study, we have to determine first the ligand here. Determine the ligand or natural compound to be explored, and then the second step, and make 3D structure to the compound. Exerting can use the PubChem, and the third, determine the target protein through network pharmacology, and then the next step is prepare the compound and target protein, and 5, perform molecular docking using this software, and the result obtained are in the form of binding affinity value with units of calorie or per mole. So the ending of step, visualization using BioVia discovery. So I explain the step by step. Okay. So in the first step, we know that the TRPV protein structure we can find in the PubChem, yeah, compound. This compound that called Z-but2 anidoic acid, yeah, from PubChem. Yeah, malic acid is analog with Z-but2 anidoic acid, yeah, and also we find the protein structure, the TRPV4 structure, we can find in the by downloading FASTA from NCBI and the modeling using the Swiss model. So, how about next? Nah, the resume for the study, we uses the following web server and software. Web server, I mentioned the PubChem, yeah, uses to explore the compound, yeah. The figure in the computer is PubChem. And also the second step, we explore the protein from FASTA and CBI. This is the figure in the computer. And this, the Swiss model used to model the TRPV protein. We can see in the computer is the logo is Swiss model. Also the next, this is used to create pharmacological network of Z-but2 anidoic acid compound with various protein. We see it in logo like this. Okay. Also the next step, still web server. Yeah, we use to analyze physicochemical, pharmacokinetic, and drug likeness properties of Z2 anidoic acid. So the logo here, and also the final step is use protox to predict the toxicity of compound of malic acid or but to anidoic acid, that is protox. Okay. Yeah, I hope this study is cannot feel boring, yeah, because with the computer we can see everything is fun. Okay, now with the software we see the PyMol. Software is we can buy the software, yeah, not from the web server. Yes, if the software we must buy first. PyMol used to prepare protein compound, yeah, that figure here, and the Pyrex used to molecular dogging, yeah, fit and prescription, and then the next BioVia used to visualize molecular dogging result. So how about the result? This is step by step, yeah. In the first, we take a look in the PubChem. We see the malic acid. We explore the malic acid. So we have the molecular like this, yeah. The figure of the molecular malic acid is Z, but to anidoic acid ini here. So we can click search, select compound structure in the best match section. So the third, select the 3D conformant and download, yeah, red arrow here for download, and copy the canonical smile and save in worksheet is a blue arrow. Okay. Also the protein target, we can look for in the like this NCBI. We can see this like this. Now copy the target protein FASTA and input into the Swiss model. So okay, next, this is the Swiss model. That the FASTA into the following column. Click for build model. And then next, analyze all physical, chemical properties, pharmacokinetic, and drug likeness. We see the Swiss ATME, Swiss drug design. Yeah, this is from canonical smile input a column. And then also analysis of toxicity. Yeah. And next step is molecular dogging with Pyrex software. This is the model for the compound of the malic acid. Yeah. So we can look for the binding affinity data, and RMSD score are obtained in the following section. See the result of the binding affinity, and then so we can see also the visualization using biodiscovery, so that molecule can reflect with the visualisasi in computer. So the molecule like this in the figure, visualizing using via discovery, yeah, to obtain hydrogen bond distance and bond types between protein and ligand complex. This is, okay. Next, still the research method. Okay, the resume of the step. Yeah, we see the 5 step. Yeah, the step 1 is tool material preparation. Yeah, from web server, and the second we'll look for the target protein using pharmacological network, and then the third see in software too, and the fourth preparation of the RPP and ligand using PyMol like this, and also the 5th step is visualization. This is the resume of the step before. Okay, now how about the result and discussion? we see that the pharmacokinetic test show that the compound of Z-but2-anidoic acid was well absorbed in gastrointestinal tract. And then here, yeah, so we can see this is the data from the Lipinski rule of 5. We see in a pharmacological book, textbook, yeah. Okay, and also next, this is the toxicity test also can define in predicted LD50, yeah. The predicted toxicity value is shown in the toxicity category of class 4, which is considered harmless to living things because we can see the 500 milligram per kilogram berat badan ya kurang dari LD 50 lebih dari 5.000. Nah ini ada, there is in the figure or table. Okay, how about next? So the result and discussion, we see toxic doses of given LD50, yeah, meaning the dose at which 50% of test subject die upon exposure to the compound. So toxicity class according of classification labeling are given in here, like class 1, class 2, class 3, class 4, class 5, class 6, yeah, fatal, toxic, harmful, maybe harmful, and non-toxic. Yeah. Okay. And the next, how about the molecular dogging? We see the result. The binding affinity of value of the RBV4, yeah, showed a value is minus 4.1 cal per mole with RMSD of Armstrong. So what's that meaning? The meaning is binding affinity indicates that the strength of the bond between the protein complex of the ligand, the more negative means the binding affinity value. So that means the stronger the bond. And so we see the visualization. Yeah, the hydrogen bond. We see the hydrogen bonds are formed at amino acid residue more than 2.7 Armstrong. So that means it's less strong, kurang kuat. Yeah, that indicates that the bond strength of the RBV with Z-but-anidoic acid is less strong. Okay, next. And then the ligand, how about the ligand protein? We saw the aromatic type or blue arrow can strengthen the hydrogen bonds in the protein ligand complex. So here we can find the pain mechanism with the in silico study. Yeah, so the stimulation of tooth bleaching agent, yeah, through the cell membrane, yeah, like here, TRPV4 will bind, yeah, in normal condition, TRPV4 will bind to natrium, resulting depolarization and pain response. And received by the peripheral nervous system. Yes, you can see afferent here. And then also here, yeah, we respond with the C fiber of type C afferent nerve. And then this is the but2-anidoic acid will compete with natrium to bind to TRPV4. The stronger bond between anidoic acid and TRPV, the more natrium cannot bind. Yeah, so the malic acid or Z-but-anidoic acid can inhibit pain relief. This conclusion. The compound of Z-but-anidoic acid can be used as the candidate TRPV inhibitory agent. So in the clinical application for the use for the whitening teeth, yeah, we can see the malic acid need furthermore research, yeah, for the concentration. But the malic acid is safe, yeah, because can use as the pain relief agent during dental bleaching treatment. Okay, maybe the moderator, thank you for this. Dr. Nevi, yeah, I already finished. Yeah.
Okay, thank you,
Yeah.
Dr. Yuli.
Yes.
This is a very interesting presentation. Now we will open a question and answer session. If the participant wants to ask or share with Dr. Yuli, please, time is yours. Any question?
Maybe this research, this study, not more interesting, yeah, doctor.
No.
Because it's very complicated. Complicated, yeah.
Okay, if I may conclude that from the doctor explanation that based on research with the silicon method, it turns out that aloe vera malic acid has the potential as bleaching agent that has the ability to restore tooth brightness, which also is able to inhibit the hypersensitive.
Yeah.
Is it correct, Doc?
Yeah.
Okay.
That's correct.
My question is, would you like to explain why you choose the in silico method for this research?
Okay, yeah. In silico maybe is not the new research, yeah, but in silico is already done in many study, yeah, in pharmacy and medicine, yeah, because the in silico can application, yeah, for drug design as a modeling, the interaction of drug molecule with biological. Also, we can see the genomic and proteomic analysis. Also, the computational toxicology prediction, and also we can see the metabolic pathway simulation, yeah. This method is already widely used, yeah, because it is a very efficient and more economical and able to handle complex analysis more quickly, yeah, because in silico is often used to complement in vitro in vivo method, yeah, this leading up to research process, yeah. So in silico is more practice that I mentioned before, Doc. Yeah, we cannot go to the laboratory. Yeah, we just make a simulation with computerized, and then we can see the result and prediction of the drug, yeah, or delivery the drug, also the pharmacokinetic, and also the toxicity. Like that, Dr. Nevi.
Yeah.
Okay.
So this method is very helpful and for valid research, Doc.
Yeah.
And for the student, it is very helpful to them.
Yeah.
Yes, Doc.
Yeah, yeah. Especially in pandemic, yeah, in pandemic or in online zaman online, ya, zaman kekinian, the students mungkin lebih memilih utak-atik ya, penasaran di komputer seperti itu ya dok ya, saya jawab dengan basah. Nah ini mungkin lebih untuk generasi zaman sekarang ini mungkin mereka ini lebih pinter dari kita ya, karena zamannya beda. Sehingga mereka kalau menerima tentang in silico, tentang apapun yang ada di komputer, itu tentunya lebih cepat dari kita gitu dok. Jadi ini juga menggambarkan bagaimana kita tidak perlu atau melakukan penelitian yang membuang-buang. Kita harus beli bahan, kemudian kita harus membeli tikus ya, seperti itu ya. Jadi kita prediksi dulu, oh sekiranya oh iya bermanfaat, oh ya nanti kita uji in vitro. Oh masih penasaran lagi untuk konsentrasinya, tentunya kita perlu uji in vitro, uji in vivo, seperti itu. Itu dok.
Ya, mungkin bisa saya sampaikan dalam bahasa Indonesia. Jadi sebetulnya penelitian Dokter Yuli sangat menarik ya. Beliau tidak hanya bisa mengangkat, maaf Dr. Elias, saya bahasa Indonesia saja dok, daripada saya terbata-bata. Dokter ini membuktikan bahwa asam maleat dari aloe vera itu tidak hanya bisa untuk memberikan kecerahan ke gigi, mengembalikan kecerahan gigi pada kasus-kasus diskolorasi, tapi juga bahan ini juga bisa bekerja untuk menghambat hipersensitif yang biasanya terjadi kalau kita memakai bahan bleaching, gitu ya dok?
Iya.
Luar biasa dok, kita beri aplaus untuk Dokter Yuli.
Terima kasih.
Dengan metode yang sebetulnya tidak sederhana-sederhana juga, tapi sebetulnya update ya dok, karena kita pakai AI ya. Jadi pakai dengan memakai komputer, software saja kita bisa membuktikan. Nah kemudian nanti baru dilanjutkan ke penelitian in vitro dan vivo. Dan ini memang sangat-sangat menolong untuk adik-adik yang sedang sekolah, mungkin bisa memakai metode ini dalam melakukan penelitiannya, jadi biayanya lebih murah dan hasilnya tidak diragukan, seperti itu dok. Terima kasih banyak dok.
Ya.
Ada yang mau bertanya? Ya silakan tuh, kalau bahasa Indonesia langsung ini dok.
Ya. Okay.
Ini Inggris juga boleh dok.
Iya dok. Assalamualaikum Dr. Yuli. My name is Pocut Angelina. I'm from Conservative Dentistry Resident. I want to ask you about why do you choose the method between docking and molecular? And the next question is how we can validate this silico study, because when we do an in vitro or in vivo result study, we can do so many type of confirmation like photo, micro, or any else. And the next question is where we can do this type of study in silico study. Thank you, doctor.
Yeah, thank you for the question. Yeah. Anyway, the in silico study, why I choose this? Yeah, because I have many research with the in vitro, in vivo, yeah, for the student is more complicated, yeah. Yeah, I see the research is more good, but I think we can see just from the computerized, yeah, we can look the prediction, just the prediction, and then the result, yeah, what's next, yeah, so we can see, we can arrange to, yeah, about our roadmap research, yeah, so if we go to in vitro, but the in vitro is the result is still need more see the comparing, yeah, comparing, just need for many follow up for the laboratory, yeah, but just from the in silico we just see the prediction, so we cannot follow up for the step in laboratory. Make it simple, ya. Jadi apa ya, lebih dipermudahkan, sebetulnya lebih dipermudahkan. Jadi kita nggak perlu, kalau in vitro itu, oh kita tahu konsentrasinya nanti dari reference 50%, 100%. Ini masih diuji lagi. Nah, kalau dari sini kita mungkin nggak perlu karena itu tadi kita bisa memprediksi tentang bagaimana potensialnya dulu ya, potensialnya ya. Mungkin ya saya masih masih melihat menghambat nyerinya for dental pain ya di sini nih. Tapi mungkin saya juga penasaran malic exit-nya sendiri itu seberapa sih konsentrasinya yang bisa memberikan efek sama dengan carbamide peroxide. Di systemic review masih saya temukan karena belum banyak evidence base ya, masih kurang keasamannya ya. Jadi beberapa studi herbal plant memang belum sekeras atau belum oxidizingnya belum sebesar kalau bahan kimia. Nah, tapi tentunya di Indonesia ini karena bahan herbal banyak dan lebih tidak ada efek sampingnya, why not ya? Kita follow up untuk herbal plant Indonesia ya, karena kemarin saya studi ya, bukan studi ya, hanya studi banding ya di Taiwan atau Taipei. Semua bahan dari herbal itu memang sudah didukung pemerintah ya. Jadi semua di rumah sakit itu sudah disediakan bahan-bahan herbal. Jadi pasien tinggal pilih, kalau kamu mau bahan herbal it's okay. Tapi kalau kamu need a doctor it's okay. You can receive the formula or kimia ya, chemical receive ya, prescription from the doctor like this ya. Jadi memang harusnya kita nanti juga harus didukung ya, karena jamu itu kan sudah dari dikti ya, itu sudah disebutkan bahwa itu juga merupakan concern dari pemerintah, tapi belum tindak lanjutnya harus perlu langkah lebih seperti itu. Gitu mungkin.
Okay, any question?
And
Yes.
then where, Doc, we can do this kind of study?
Okay.
Yeah.
This study. Mungkin Dr. Nevianti mau mendatangkan study in silico katanya.
Iya, Dok.
Iya. Ya mungkin nanti diajarkan dulu ya Dok ya, pakarnya. Biasanya pakar, saya juga nggak pakar bener ya. Ada pakarnya itu biasanya dari fakultas MIPA.
Okay.
Mereka ini ya karena biological, biokimianya lebih pandai. Kalau saya sebetulnya klinisi, tapi hanya penasaran aja karena selalu membimbing mahasiswa. Oke, jadinya apa ya yang paling enak masa pandemi kemarin? Oh ya ternyata ada in silico gitu ya. Oke lah, daripada ke labnya juga ngantri, nggak boleh kan waktu pandemi. Nah, sebagian ada systemic review, sebagian dilanjutkan in silico, seperti itu.
Baik dokter, thank you dokter.
Iya, sama-sama.
Oke, Aini? Oke.
Selamat sore dokter. Assalamualaikum warahmatullahi wabarakatuh. My name is Aini. Going to ask you a question. How accurate silico models in predicting complex molecular interaction? Thank you.
How accurate ya. Aini is from Brawijaya too ya. So I always remember because the first student ya, angkatan pertama di Brawijaya. Sekarang memilih USU ya untuk SP-nya. Okay, I need the accurate. How is the accurate? Okay, maybe next ya. I want to share about my clinical study ya, not my clinical ya, my lab, my experimental ya, but hasn't not yet. The study ya, several study is mentioned that the in silico and then with the experimental study is the accurate ya, ada akurasinya ya, that's accurate. Oh, sorry, I have the second master ya, bimbingan di biomedik ya. He also find in silico study and also find the experimental study. Itu akurat ya, tapi in nano emulsion gel, rosemary and nano ya. Oke, ada saya sih sebagai pembimbingnya, nanti bisa search ya di situ. Dia sebetulnya karena harus di deadline untuk submit. Nah, ternyata studi in silico ini ternyata bisa submit dulu ke Q3. Nah, itu syaratnya ya. Jadi kalau nantinya kita sudah penelitian lama, terus kita harus submit, itu juga banyak review dari ini editor ya. Nah, menunggu sekian lama antri ke jurnal itu pun tidak membuat sabar kita, maka ini bisa menjembatani untuk submit duluan ya. Jadi in silico ya kita flashback. Nah, waktu itu saya tawarkan, udah namanya Kak Widi ya. Kak Widi ini aja coba di in silico kan dulu aja sambil kita menunggu accepted yang benar yang experimental study-nya. Nah, ternyata dia bisa diterima di Q3 dan lumayan ya bisa segera lulus ya. Seperti itu Aini. Oke, mungkin Aini mau coba.
Oke. Oke, Dr. Aini. Oke, another question? MC? We have time? No? Sorry, okay. Due to the time constraint, we sorry that we cannot continue this question and answer session. If you have more question, maybe you may ask the speaker directly out from this session. Ladies and gentlemen, we finally come to the end of this discussion session. I'd like to thank the speaker, Dr. Yuli, for the amazing, informative presentation, and all of the participants who have attended this session. I think that's all from me. Let me membacakan pantun lagi. Ini lagi gila pantun.
Cakep.
Saya sebetulnya mewakili Dr. Yuli. Sarapan pagi makan nasi tambah ikan.
Cakep.
Karena salah. Ya betul. Hati-hati jangan termakan duri. Sampai di sini yang Dr. Yuli sampaikan karena beliau sudah lelah berdiri. Thank you.
Thank you.
Please MC.
Thank you to the speakers, Dr. Yuli and the moderator, Dr. Nevi.
Next on, we would like to present the certificate to the speaker and the moderator given by Dr. Fkg Usu Conference Fkg Subspesialis PKOA Consultant to Dr. Esi. Time is yours.
Thank you to all the doctors. Please give an applause once again to all of our doctors. Okay, we finally reached the end of today's event with spectacular lecturers on topics that are highly beneficial for us as a dental healthcare professional.
And don't forget to attend tomorrow, where we will have even more captivating speakers with their great topics. Last but not least, I'm Haniani Sanabila.
And I'm Sakwari Bikbar saying goodbye.
Wassalamualaikum warahmatullahi wabarakatuh.